Okay.
All right, great. So Aimee, thank you very much for coming, and Artie as well. And also thank you very much for keeping us out of trouble and helping us code our cases and notes, etc. So, and with that, I want to hear where we're deficient. So help us out.
Okay. All right. Well, good morning, everyone. I'm Aimee, so I'm the Senior Coding Coordinator for the Department of Neurosurgery and Neurology. And this is your provider professional coding team. So I know Brenda was here last week, and we learned that there are lots of people looking at your documentation, and we are one of those teams that are looking for appropriate documentation so that we can assign your professional billing CPT codes. So we collaborate at times with the facility coders and the clinical documentation specialists or clinical documentation integrity team. And you will see emails and in baskets from all of us with good information that we ask you to reply to. Okay, these are our topics of discussion. As usual, we're going to approach the situation as not teaching you how to code, but rather teaching you how to document so that you're compliant with Medicare's billing rules and the AMA billing rules. And a lot of people will ask, why do I want to know this information? Well, here at UW, you're fortunate that you have coders and we professionally code everything for you. But as you get out into your own practice someday, you may want to know this information. And I can tell you that every year we've had a fellow or resident leave our practice and ask us if we have a cheat sheet, or sit down in our office and say, can you teach me everything you know in an hour? And I think some of our new coders like Jesse and Artie can remember back that you don't learn coding overnight. It's a practice as well. So where we get our codes from is our Coding Bible. It's our CPT book, which is mostly online now, if you've ever heard of 3M or Super Coder or Select Coder. So all technologies that you need to purchase, but within this book, there are 5-digit codes that, of course, serve as communication among a lot of people, as you can see here. I would like to note that the codes that you report through our op log for the ACGME is not exactly appropriate billing. So when you get out on your own, you don't want to use those codes particularly for your billing. However, the ACGME asks us to report things a little bit differently, so we've worked to cross-map our codes so that you can report them. These procedures codes are updated and reviewed yearly by the CPT editorial panel. If you feel that you need to have a code developed for you, there is a long development process actually, and the AMA well, actually the ANS, your associations are really great at supporting that and moving that along. So I'm not going to get into a lot about RVUs, but I think it's important to touch base about it because a lot of comp plans now are looking at physician work RVUs for reimbursement or your pay scale. So here is an example of a herniated disc. RVU is actually the methodology used by the Centers for Medicare and Medicaid Services and private payers to determine physician payment. So you have your physician work RVUs, which is, of course, your technical skill, your physical effort, your mental effort, patient risk, the amount of time it takes you to perform a procedure, and then you have your practice expense, of course, that's your administrative staff, your billing space, your medical equipment, your office supplies, and then malpractice, which is your professional liability. And under the resource relative value scale, physicians are reimbursed. So I'm not going to get into this. It looks like an awful math equation, but they do use a geographic practice cost indices, and a conversion factor along with the total RVUs to come up with your payment.
So the bottom line about that, sorry, this is Dan, is that they can do some microeconomics to try and improve the reimbursement in underserved areas in Wyoming and North Dakota, or give you a little extra money for malpractice if you live in Pennsylvania. So it's an interesting how all those little pieces can weigh into how you get reimbursed.
Absolutely. We could talk on this for an hour, but we'd really all be sleeping then. So that's very interesting. So we're going to start off by talking about
Aimee, I'm just gonna say one more thing. I'm sorry. Even though it seems like you would be, the most highly attended courses in the annual meetings are the coding courses.
They are.
Yeah, because everybody wants to know it after they're done. So I'm glad you're teaching everybody now.
Oh, that is great. So now I'm going to put in a little plug right now. So yearly we go to the AANS coding and documentation updates and management actually. And they have a company that works alongside them, Zupco and Associates. So they know, all of the reimbursement part of coding as well. So it's a well put together conference, and I suggest residents and fellows as they get out on their own that they take this course. I just talked to Casey Madura about it actually. So, but I have to say that I feel, and Artie, you can tell me otherwise, there aren't a lot of providers. I feel like there could be more in our conferences, but that's, one location. So that's really great to hear, Dr. Brooks.
Aimee, can I add something quick? This is Benny.
Yes.
So at the pediatric board, it came to our attention this past year that one of the two most common causes of failure in the oral boards of a pediatric candidate is coding. First, their case indications, and second, their coding. So the pediatric section set up a coding webinar. It's a 1-hour webinar that's on our website. That's excellent also for pediatric coding if anyone's interested, and I can send a link.
Super. That's new, correct? I think at the ANS, they just told us that just became part of the boards.
It's been going on for the last 3 years or so, and basically the board has identified a number of common coding scenarios that are frequently done incorrectly. And the issues for the residents when you submit your cases, we want the codes that were actually billed, not ones you think should have been billed. And some folks have gotten into trouble because of just clearly fraudulent coding practices, such as billing partial corpectomies for ACDFs, overcoding TLIFs, stuff like that, and in the pediatric world as well. And a lot of this is due to the fact that a lot of people like me, for example, don't do my own coding. We have Aimee and her team that does our coding for us. So if I want to know my codes, what I need to do is I need to get a downloaded Excel spreadsheet of my codes, and I need to report those, as opposed to just going to the book and making them up myself. It is important that you know the principles of this, and it's important that you make sure that you have someone who knows what they're doing help you with this going forward. But know that the board is looking at what you are actually coding.
Okay. And know that we are available to you if you need any help by email. We're back in the office on Tuesdays and Thursdays next to the Javid room, so we're always available to help you with your questions. All right, so back to documentation completion. Many people, again, rely on your documentation. The record is open now for patients to read, so it's very important to work within these guidelines the best that you can. We're also trying to leverage delinquency reports. I'm sitting in a subgroup regarding that right now, so we can figure out the best way to communicate to all of you. Okay, so before we embark upon our surgical coding and documentation, let's talk a little bit about the surgical global package. So there's actually 92 days of global package. It begins the day before the operation and goes through the 90 days after the procedure. Most of our postoperative period is 90 days. There's also a 0 and a 10-day global period. I'd like to mention that if a patient comes in urgently, we can code that admission. It's with a 57 modifier to let payers know that, hey, they came in, the decision for surgery was made that day. So, and then we have intraoperative time. So that's all of your x-rays, your ultrasonic aspirating devices, EEGs, evoked potentials, of course, go to our neurologists. Loop magnification is different than using the operative microscope, and then all your surgical drains. And then postoperative, which is speaking with the family, inpatient, subsequent days in the hospital, and then follow up in clinic the remainder of the 90 days. Okay, I always have this slide in here. Documentation is important. Please document everything that is medically necessary. Often we say you do more than what is documented, and we just want you to get credit for your work. There's an initiative going on within the hospital right now to work on templates to make it efficient for doctors to capture all their work. It will also reduce the queries that you get from people like myself or the hospital or our clinical documentation specialist. So one point that I would like to make about this is that this is kind of, your beginning, your operative indications, and everything here that's listed needs to make it into the body of your operative report. That is where the coding magic happens. We abstract all of our codes from your body of your note. So if we happen to see that, you're talking about the L3, L5, in the indications, but as we're reading the body of the note, we only see L3, L4 mentioned. That is when we reach out to you. If it says up here that you're doing laminectomy, facetectomy, foraminotomies for decompression, and we don't see all that bony work within the body of your note, then we reach out to you and ask you, did you in fact remove all this, and would you like to make an amendment to your documentation? Okay, we're going to talk a little bit more about spine coding than we usually do during this presentation. So let's look at some of our principles of spine coding. It goes heavily on diagnosis, what the approach is, how many vertebral levels are you working on, and I know that sounds all reasonable and that you'd put that on your documentation, but sometimes we do find ourselves questioning some of this. So it's always great to make sure that you are mentioning all of this in your documentation. Was there decompression? How many nerves were decompressed? And then fusion type. What was your graft? Was it allograft, autograft? Are you putting PEEK in? Are you using a bone aspirate? So all important information. Okay, and then just general spine documentation reminders. When you're performing a corpectomy, it's very important to put in that 50% of the vertebral body was removed in the cervical area, at least a third in the thoracic and lumbar area to justify coding. So we may reach out to you when we see this missing. When I think of like ACDF and microdiscectomy, just making sure that you are documenting each level that you're doing work at. When you're doing a microdiscectomy, are you doing it bilaterally, and are you documenting that it's done bilaterally? There are no codes for thoracic disc removal, so we we tend to go for transpendicular or costovertebral or an unlisted code. And then there's the TLIF and the PLIF, which there's always, I think within the last 5 years, coding has changed each year and how we're going to report this. So we'll talk a little bit more in detail about that. I just wanted to show you the difference between laminectomy and laminectomy, facetectomy and foraminotomy. So what happens is the AMA puts out, our CPT book with all these guidelines on how we're supposed to document, and then the payers come in with their own guidelines and expectations of how we're going to bill these. So people from the insurance companies that are looking at your documentation don't always have the best background and often will ask to escalate it to somebody clinical to look at so that we can get reimbursement. And this is an area that we get stuck in quite a bit because you want to document all the bony work that is being done. And, are you going to the lateral recess? Are you staying within the spinal canal? So these are all important things. And I thought I would just assign the work RBUs to these. You can see that 63047 also has an add-on code for each additional segment. But when you go over to the laminectomy, it's you actually bump up a code. So you have 1 or 2 vertebral segments, and then beyond that, you're going to bump up to the 63017. Okay, and then we get into the TLIF, PLIF codes, and it's really, do you code the decompression? Do you not code the decompression? And basically what this is Medicare versus the AMA and the coding guidelines. So if you're doing an interbody fusion, bilateral decompression at the same level, Medicare says that you cannot bill for the decompression at the same level. So what we've been guided on through the AANS is, how are we going to be compliant and maybe still capture this for your work RVUs and the work that you're actually doing? Because remember, the CPT says that we can bill a decompression at that level. So basically what this chart says is that when it's Medicare and you do a decompression at the same level, we are going to bill the decompression per se with a 51 modifier. Medicare is going to deny it. We, of course, accept the denial, but you're still getting physician RVUs for that. And then if it is a non-Medicare payer, which some payers follow Medicare and we still get denials, but CPT says that we can bill the decompression at the same level, just with a 59 modifier saying, hey, this was a separate procedure. And here is where documentation comes into play as well, because you need to state that the decompression of the nerve roots was done bilaterally, because, work for one side is already within the code. So if we drop down to the lower portion of this procedure and we do a bilateral decompression, and then we do an adjacent level, we don't report the decompression at one level. We can report with a 59 modifier at the adjacent level for Medicare, just the opposite for non-payers. I'm sure this is clear as mud. So if we come here and we actually look at a case, this is how we would code Medicare versus non-Medicare. Any questions or comments?
My advice is just report what you did, and then the coders will work this out. This is a matter of great controversy at the present time, and will probably change again in the next couple of years.
Absolutely. And that's why we are appreciative that we are sent to the ANS, because every year we do get great information from them. Things change. We learn how things are reimbursed. it helps us to be more efficient and send out a clean claim in the beginning so that we don't have to spend our resources on denials. So we're going to go over a little bit of endovascular coding today. It's a little bit more complex, but once we get it under our belt, it's kind of fun coding. We notice that when we go to conferences, no one likes to present on it. And it's a very short portion, and usually it's at the end of the ANS, and everybody gets up and leaves the room, and we kind of laugh. But we've also noticed in the last few years more people are attending, so the practice is growing. So what we're looking for is diagnostic and therapeutic procedures. We code by vascular family or territory. We code for moderate conscious sedation. We're looking for the vessels that are actually catheter imaged. We look for follow-up projections and if 3D was performed. And it's really what makes this complex is we're also looking, if there is an intervention. Sometimes you can code caths, sometimes you can code images, sometimes you can't. So that's all goes according to the rules of the AMA. So this is some documentation that we look for. And I have to say, we've been talking to Jacob, who has been kind of taken the lead and been a great advocate for cleaning up templates and proper documentation. And it's, we're still working on all of this. But Jacob, if you're here, we really appreciate the collaboration. So we look for 3D angiography and the appropriate documentation that you see on the screen. And of course, there's appropriate documentation for conscious sedation, which we can code with these as well. It changed a couple of years ago. When is an angiogram separately billed with an intervention? There are lots of rules around this, so we have to be careful and watch. When no prior angiogram is available and full diagnostic study is performed and the decision to intervene is made, then we can code for this. Medicare looks at a CTA as prior imaging as well. So we kind of have to dig into the medical record for that. If the patient's medical condition changes prior to study, if the study is visually inadequate, or if there is a clinical change while you're working on the patient, then we can bill angiograms separately. One area that's a little tricky to maneuver when you're coding is actually carotid stent placement. Medicare came in and put all these restrictions on using this code. So what they're looking for is distal embolic protection device. We realize that there are emergent situations where you cannot use this device, and we have not had much luck getting Medicare to pay for these, actually, because it is written within their policy that they do not want to pay without the protection device. So what this code includes is stenting up to the carotid bifurcation. So we're asking you to make sure that you document clearly what segment of vessel that you are in. And I put in some documentation that, Medicare looks beyond the procedural note for reimbursement. So they're looking to see in the documentation, is this patient high risk for an endarterectomy? Are they symptomatic? Do they have stenosis that is greater to or equal to 70%? Any questions on endovascular coding or comments?
There's an interesting comment about the, excuse me, the distal embolic device that they would kind of force providers to use it via an economic lever, I guess.
Good way to look at it, yes. Okay, principle of cranial coding. So we're not getting into a lot of guts of skull base, but you can always come to us and we can talk about that. There's a lot of documentation of bony removal and pathology removal with skull base codes. So principles of cranial coding is a lot of pathology driven. We look for if the microscope was used for microdissection, any kind of stereotactic navigation that's not already part of the CPT code so that we can code separately. Ventric placements, ICP placements when it's outside of the craniotomy being turned, lumbar drains, any kind of extra graft material that comes from another part of the body, and then cranioplasty. We're always looking for you to put the size of the cranioplasty along with lesion removals. We need the size for those. Aneurysm repairs. Always document everything that you do within there because we're looking between two codes, which is simple and complex. And I've heard people say every aneurysm is complex. So what AMA says is complex is here for you. So it's the size, it's the incorporation of multiple vessels. It's temporary vessel occlusion or trapping. Sometimes we do neck dissection. Ventrix as well. We're looking for, are you creating a ventric with a twist drill, or are you using, a drill cutter? The verbiage makes a difference. So, and then your operating microscope. The big key word here is we want to see that you are using it for microdissection. If you could use that word microdissection, that's going to make payment smooth for us. We're not going to have denials. We do come across a few denials for this. And there are also codes that we use that we cannot report the microscope with. So that would be our pituitary tumor removals, our ACDFs, and our nerve repairs. Stereotactic navigation. So the big word with documentation tips on this is that we're looking for your pre-planning documentation. What are you doing for your pre-planning, and then when are you bringing it into field, and what are you using it for? Also, the name of the system that you're using is very helpful. So these can be highly under scrutiny by payers. This is a fine example of stereotactic navigation. They're talking about the registration. They're talking about the O-arm, and that the pedicles are being tapped under navigation. And then at the end, it kind of sums it up and says that the self-navigation was used throughout. And here is a brain example talking about registration, confirming location, and when they're bringing it in to dissect or to work on the pathology. Okay, so modifiers. We're gonna jump into a little bit of that because they affect your documentation and your reimbursement. So these are modifiers that we put on the CPT codes to tell the payers a little bit of a story. So we have increased procedural services. There's a lot of documentation that's required for this. So the more you can tell us about the additional work that you spent, the intensity of the procedure, the patient's condition, it will help us to describe the story to the payer.
Aimee, is there a BMI? In spine, the weight makes so much of a difference. Is there like a BMI cutoff that when we can use this? Because sometimes it's just torture.
Right. So there's not a cutoff per se, but we have been coached through the ANS that if you're using 22 modifiers strictly on BMI, that there needs to be detailed documentation as to the difficulty.
Understood.
Mm-hmm. And that's kind of what this screen also tells you is, you know, please tell us that the procedure was risky and time consuming and that, you know, you had adhesions to work through. Okay, so this is a really great slide because I've been really good historically with finding doppelgangers. So I personally think this looks a little bit like Dr. Dempsey and maybe Dr. Machio Pinto. I know I haven't heard his name for a long time, but usually I have Dr. Iskandar in here somewhere, a fun picture that I had found. So that's kind of fun. But this is our modifier for saying that two surgeons are working together. This is kind of an interesting modifier because Medicare, of course, and the AMA look differently upon this modifier. So Medicare says it has to be two different surgeons of different specialties working on different issues within the one procedure. AMA just says that it has to be two different surgeons working on different components of the same procedure. So not all CPTs and procedures allow for co-surgery, but from prior some of our prior grand rounds, I know Dr. Dempsey is a big advocate of standard of care and working with our patients when they need two surgeons. So these are some co-surgery examples of good documentation where each provider is stating the work that they did within the surgery. And then we have our assist modifiers when there's not a qualified resident available. That also takes a lot of documentation. Only one of the surgeons needs to document, but you need to document that there was not a qualified resident available. Okay, this is Ellison Bay and Door County, and I'm hoping to head there tomorrow. But are there any questions or comments?
Aimee, yes, Dr. Keenitz has this question. She states, sometimes the stenosis is so tight that distal protection device cannot be used for initial angioplasty. Is there any wiggle room for that or a way to code this in order to be paid by Medicare?
Unfortunately, no. We have actually, I think we've had a couple instances where we've tried to appeal to Medicare and they haven't budged. But that is really a good thing for the associations to pick up because maybe it's time to submit some new documentation to Medicare to try and get that changed. Because I feel like we have a handful of patients that we do this on urgently every year. Artie, do you have anything to add to that?
Well, yes, in some cases, I know Dr. Keenitz's question is about Medicare. I see a lot of cases where our patients come with carotid dissection, and in those cases, they don't use an embolic protection device. Those cases a lot of times are not Medicare, so we are able to get reimbursed on most of them, but Medicare, no.
That's a great question. All right. Well, I thank you all.
Thank you, Aimee. Thank you very much.
Very good.
Much appreciated.
Thanks, Aimee. That was great.
Yeah.
Thank you.
And for all of us at every level, it's very important. Thank you.